personal experiences because it's been a very interesting journey for me. People ask me how I can do what I do since I probably sign more death certificates in the county than any other doctor. I round every day at Hospice House, which is located up the street, pretty much 365 days a year. My partners will cover me occasionally when I go on vacation, but I've already been there once today. I would have stopped tonight, but there were no new patients, so I'll stop tomorrow morning. I got into this in 1990 because my father died from mesothelioma, and he spent the last 4 or 5 days in agonizing pain in the hospital in Philadelphia. At the time, there was really no mention of hospice. There was no mention of palliative care. There was just mention of more procedures and more injections and more taps and draining fluid and all this stuff. He and I had a discussion before that. He didn't want any of that, and there was no sense to it, and it really got to the point where there was no sense to it. Then on top of that, after he passed, my mother was left with no support other than me, 100 miles away in northeastern Pennsylvania, and my sister burdened by that problem in Philadelphia. So I had the opportunity after that to work for Lehigh Valley Hospice, who moved into the county, and I did some part-time work for them. Then they withdrew from the county, and all the people that were working for Lehigh Valley Hospice went and started working for VNA Hospice, except for me, because they already had a medical director. So about 5 years later, they came back and said, we really want you to be the medical director because you were engaged, you were interested. And I did become the medical director. I've been the medical director for VNA Hospice for about 15 years.
So fuzzy.
In 2008 was the first year that there was a board certification in hospice, and the eligibility was you needed to have a certain number of contacts with hospice patients. So since I had enough contacts because of my experience, I was able to sit through the boards, and I passed the boards in 2008. I'm board certified in internal medicine since 1983 and hospice and palliative care since 2008. That's my background, and that's where I came from. First of all, I'd like to tell this slide because palliative comes from the Latin word palliare, which means close, cover. And in palliative care, we worry about taking care of symptoms. So palliative care focuses on providing patients relief from symptoms, and that's why I tell people we're covering the symptoms. In this country, over half the patients that die in American hospitals die with pain. Unbelievable statistic. Just some definitions, because it's hard. People don't understand palliative care. When I do a palliative care consult in the hospital, everybody thinks I'm the hospice doctor. And palliative care and hospice are really the same but different. Palliative care is a holistic, multidisciplinary approach that includes specialized medical care for people with serious illness. It focuses on providing patients with relief from symptoms of pain, nausea, vomiting, constipation, and stress of serious illness, whatever the diagnosis and whatever the symptoms. That's a big misconception. People think if you're in palliative care or you're hospice, you have to have a cancer diagnosis. That's one of the many disease processes that we deal with, but it's not the only one. And it's holistic because we don't just look at the heart because we're a cardiologist, and we just don't look at the lungs because we're a pulmonologist, and the kidneys because we're a nephrologist. Really, what I think, the only doctors that are looking at the whole patient. And when I say the whole patient, I don't just mean the whole patient, I mean the patient and the family and the siblings and whoever's intimately involved with the care of this patient. Care is provided by a team of doctors, nurses, and other specialists, social workers, chaplains, pain specialists, and others who work together for the patients, with the patient's other doctors to provide an extra layer of support. And it's appropriate at any age and any stage of serious illness and can be provided along with curative treatment. We'll talk about that later because there's some interesting data on that. And I think that's a big point is that people think hospice is, oh my God, they call it hospice, I'm going to die tomorrow. Under Medicare, you can be on the Medicare hospice benefit for 6 months. And if your condition continues to decline, it can be renewed for another 6 months. So you can be on hospice for an extended period of time. And the thing that bothers us as hospice providers is that lots of times there's so much we can do to support the family. We can't do that in the last 2 days of life. But if we have a relationship with the patient, get to develop a relationship with the patient and the family over those last few months of life, we can actually provide a lot of support and care. This is the most comprehensive definition. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So you can see how it's not just the physical pain, nausea, vomiting, hallucinations, delusions, whatever it is, it's also the other parts of this. It includes providing relief of pain, we talked about that. It affirms life in regards to dying as a normal process. I do this all the time, so to me, dying is a normal process. And I think in our culture, you can disagree with it, in our culture, we need to get a grip with that. There's so many times we have families that come in and they're like, what do you mean he had a heart attack? He was good yesterday. Well, he's 88 years old. And, and I know it's hard to understand that because, we hear all the time, oh, he looks great. He does look great, I look great for 62. Some people don't. But, when you peel this apart, I'm 62 years old. That's just the way it is. So I think we need, we need to understand better and realize that life is terminal. Palliative care intends neither to hasten or postpone death, and that's the law of double effect. And I go through this a lot with my hospital patients. When we talk about palliating symptoms, if I have somebody at the end of life who's breathing 40 times a minute, you can try that for a little while. Do it for 5 minutes and see how you feel. It feels terrible. It's terrifying. It's scary. If any of you have had asthma or have had COPD or congestive heart failure, it's terrible not to be able to breathe. So if I talk to a family of somebody who's dying from, say, congestive heart failure, and the patient's breathing 40 times a minute, I explain to them that I'm going to give them morphine, which could hasten their demise, could hasten their passing. That's different from euthanasia. In euthanasia, the goal of my giving morphine is to make sure the patient's comfortable. So the moral goal is to make sure the patient's comfortable. If the patient happens to expire sooner because of that treatment, that's not an issue. If the goal is to euthanize the patient, that's not legal, certainly in our state. So I try to make the patients know and the families know that when I give morphine, that I may hasten their death. It's not because I want to hasten their death, it's because I want to control their symptoms. So I always have a discussion with the family about that so they understand. It integrates the psychological and spiritual aspects of patient care. We're going to talk about that a little more. It offers a support system to help patients live as actively as possible until death. And those are my cues to make sure my Alzheimer's doesn't make me forget what I want to tell you. One of the things that we do at Hospice House, but you can do this as a palliative care doctor, it's better to do it as a palliative care doctor because when the patient's still with it, is we celebrate our vets. Every vet that comes in the hospice house, we have a little ceremony. We have some retired vets who come around and they read this to them. We want to acknowledge your service to our nation. Being a hospice mother kind of wants to thank you for your service to our nation. Thank you for the sacrifices you made and your willingness to serve our country. You endured hardship. You were willing to risk your life to maintain freedom and safety. They get a certificate and they get spouse gets a pin with 2 flags, the patient gets a pin with 1 flag. We also praise the spouse because the spouse has to sacrifice to let the other one go away to protect us. So it's one of the ways that we create a lot of, I think, positive quality of life. My favorite story, and this is my story, was we had a lady who was 56 years old, died of breast cancer. Her daughter was going to get married. And she, the daughter, and her father, the patient's husband, came to me one evening in the hospice house and said, "Doc, do you think she's going to be able to come to my wedding? It's in about a month." And I said, "Katie," I said, "I don't think she's going to be able to." So I could tell she was upset. So I said, "But you know what? Why don't you have a wedding here? Why don't you have a service here?" And she said, "Here? The hospice house is beautiful. Actually, it's not a hospice house, but I'll show you." But I said, "Have the wedding here, have a little service, and then you can plan your wedding as you wish, as long as your husband-to-be is agreeable." She looked at her father, she said, "I think it's a good idea." He said, "I think it's a great idea." Well, we had a little wedding, the nurses got into it, they got her gown, they got it all dolled up, and the nurses that work at hospice came, they had friends come, it was in the center, and her mother got to see her get married. So, you know, when I think about what I do for patients, I know the cardiologists open up our arteries and they do all this stuff, but I gave those people a gift that we frequently don't have the opportunity to give. And in fact, I tell that story a lot, and I told it about 6 months ago to a man who died of pancreatic cancer and his wife. And his wife looked at me and said, "Well, you know, one of the things we wanted to do is we wanted to get our wedding vows renewed. Could we do that here?" I said, "Absolutely." We set it up and it was done the next day. So, you know, we do things like that that I think are so human and so important for people at the end of their life. So we try to keep, keep them feeling good. The last thing, coffee. We had a poor guy who, when we first opened, he had a total gout obstruction. He couldn't drink or eat anything without vomiting. So they had done multiple operations. There was nothing to do. So he came to us. And every day the girls would make coffee. He would smell that coffee and drove him crazy. So I went in the room one day and I said, he started telling me this. I didn't know. I don't drink coffee. Once in a while. So he said, "You know, really, that's the one thing I miss." So I said, "You know what? Why don't you just gargle in the morning with coffee and spit it out?" He said, "I never thought of that." And he did that every day. And he was so happy. Every time I would go in the room, he'd thank me for the coffee. So, you know, it's things like that that we do that make a difference. Relief of symptoms, palliative care, we look at relief of pain, shortness of breath, nausea, vomiting, diarrhea, constipation. Anorexia means lack of appetite. Delirium, agitation, confusion. That's really scary for families when their loved one gets delirious or gets confused. Depression and anxiety. Psychosocial suffering. I think this is one thing, you know, the docs don't get. I'm telling you, I swear to God, you do not get it. I had a medical student with me about 2 months ago. And a lady came in the office. She's had multiple back surgeries. I never met her before. She has chronic pain. She was dressed in a very sophisticated manner. She had a suit on. Her husband was with her. And I could tell by her hair that she really cared about her appearance. And she told me that she gets out of the house once a week. She was about 68, 69 years old. Because she's in so much pain, she can't get out of the house. So the one day a week that you get out of the house, she goes and gets her hair done, and they go out to lunch or dinner or whatever. She says, and I have rods in my back, and if you turn around, you can see the rods sticking up to the skin. And the rods are sticking out of her back. Not through the skin, but the skin's tented because the rod's sticking up. So, and she's on some chronic pain medication. And so, I'm looking at her, I'm listening to her. She says, I can't get up and down the stairs, I gotta get up once a day. And she sits, on the backside of the house, up and down with her husband. So I'm thinking to myself, this woman's life has been destroyed. It's totally been destroyed. So I looked at her, I said, has anybody put you on an antidepressant? She said, well, I'm not really depressed. I said, let's think about this. And we started itemizing the things that she was. And she did admit that it did help her, and she was depressed. Some of the new depression medications help with pain. No other doctor had asked her about that. No one ever even brought it up. She's seen all these pain specialists, and she's seen all these other people, but no one ever mentioned it. So she was put on a depression medication that just helped her pain a little. Fear, isolation. I mean, think about it. You lose your hair, you don't go out like that. You want to withdraw from your friends. You don't want them to see you when you're sick, when you're emaciated, or maybe you're vomiting, or maybe you think you smell because you're incontinent. All that stuff, all that stuff is what's in your head while you're laying in bed sick. We don't think about it. We don't think about it. Love, faith, my wife's going to love me, is she going to take care of me? Is my husband going to take care of me? How about when I'm sick? How about when I'm incontinent? And think about it. How many people want their daughter taken care of like that? Or their son? All these fears and concerns go through our heads. Next slide. So, palliative care continues to offer support system to help the family cope with patients in their own bereavement. That's after a small hospice. Uses a team approach. And will enhance quality of life, and may also positively influence the course of illness. We're going to talk about that, but I'll tell you, we have had a number of patients, and I kind of like this. We have a number of patients who come to the hospice house, die, and they're told at Pocono or at Geisinger, Lehigh Valley, because we take patients from all over. We've had them from the University of Pennsylvania, we've had them from New York, Geisinger, Lehigh Valley, St. Luke's, you name it. And they're told they're going to be a couple days. 5 days into it, the patient's family started asking, Doc, the doctors at the hospital said so-and-so was going to be gone in 2 or 3 days. It's 5 days. And I go, well, we'll see what happens. And then another 5 days go by, and then the patient's starting to eat. We've actually discharged patients from hospice house. And people say to me, how's that happen? And first, I've learned a lot of this from my work, not from the books. When you start thinking about it, let me just paint a picture of a hospital. You go in a hospital, you're sick. Okay? The first thing they do is what? Draw blood from you. Phlebotomies have been proved not to cure any illness years ago, decades ago, centuries ago. But the first thing we do is suck blood out. And we don't do it once, we do it morning, midnight, middle of the night. Okay? So we take your blood away from you. You're healing, curing blood, we remove it. And then we put you to sleep. And then 3 o'clock in the morning, they wake you up to make sure you're okay. Well, we're sleeping soundly, and now they've woken you up. You can't sleep, right? And anybody saying now? No. So, and then on top of that, they bring a tray in, they put the tray in front of you, and then the nurse comes in, takes the tray away, says, wait a minute, your NPO, which means nothing by mouth, for a test, the doctor ordered a test, you can't, so now we're starving you. Okay, then you go downstairs for the test, you're on the table in the hallway, right? It's 10 degrees below zero, you got down. Everybody else walking around like me with ties and coats, we're all toasted warm. Okay? Then you got bad bacteria all over the place. And then we wonder why the patients don't do well. When you really think about it, is there any wonder? When you go in the hospice house, I don't know if any of you, I know, Cassie, if you go in the hospice house,
Yes.
You want to go in.
Yes.
It draws you in. As soon as you get in there, you say, oh my God. You feel like you're in some kind of holy
Heaven, yes.
Right, place. And, I learned that, if I talk too much, just don't.
No, you're making me cry. This is good.
And, I learned that when we first opened. When we first opened, I really tried to go there and see everybody right away, because I just didn't want anything to go wrong. And I rushed over there to see a lady who, by the time I got there, about 45 minutes later, she had passed away. So I'm there, oh my God. I said, we put this poor lady in an ambulance, drove her from Pocono down here. We put her in room 6, I still remember. She was there about a half hour, 40 minutes, and she passed away. So I felt bad. I go into the room to start to stammer through an apology for the daughter who was still there. I got about one sentence out. She goes, Doc, if I could have gotten my mother here for 15 minutes, it would have been worth the trip. This is the first 30 minutes of peace my mother's had in years. We don't stick people, we don't give needles, we don't draw blood, we don't do it. Everything's geared toward patient comfort. So it's palliative care comes early in the illness. We use it when people are still getting active treatment, whereas hospice is at the end of the illness. And this is kind of a representation. So basically, palliative care is kind of like hospice. We do all the things, same thing, pain control, symptom control, worry about the family, but we start the day of the diagnosis. When the patient becomes terminal, then we move to hospice. Treatment, the philosophy, everything's the same. It's really the timing. The problem is that palliative care, unfortunately, in our country is not paid for. There's no reimbursement for it. So if you put a palliative care consult in the hospital, the doctor goes and does the consult, he doesn't get paid. A lot of that actually was in the Obamacare plan, but it was stripped out when there was talk about death panels and all that stuff. So they went in and they took all that out. That was really an attempt to get people to start to think about palliative care in hospice. And that's really an unfortunate thing, because that was probably, being a doctor, that was probably the one good thing about Obamacare. Stripped out. Next slide. So most of the palliative care programs started in the 1980s. Now 80% of hospitals with over 300 beds have palliative care programs. But again, those programs were started not because there was payment for that service, but there were a lot of patients who were spending a prolonged period of time in hospitals who were dying, who had no hope of recovery, consuming a lot of resources for the hospital. So they wanted a way to shorten that length of stay so they could remain profitable. So it was kind of a backdoor approach. So what's the difference between hospice and palliative care? We already talked, palliative care is early, hospice is toward the end. So it's a specialized palliative care, a form of palliative care that's directed for patients who are in the terminal stages of their illness and approaching death. So simply speaking, hospice is palliative care for the dying patient. Next slide. So often provided, I can talk about this forever. Hospice care often provided in the patient's home. You know, I was a big proponent of home hospice 10 or 15 years ago. Now that I've seen Hospice House and I've worked there for the 8 or 9 years we've been open, I tell everybody, if you can do it, Hospice House is better. And the reason is this. When you're, let's say husband and wife, spouse is dying, the other one's trying to provide care. So the other one is the nurse, the doctor, the cook, the cleaning person, you know, trying to pay the bills, trying to do everything but be a spouse. At Hospice House, we have somebody that could be a spouse. You know, the nurses take care of the medication, the nurses take care of cleaning, making sure everything's okay, the laundry's done. It really is a much more pleasant experience. And I had a patient a couple of years ago, it was one of my patients with COPD, and husband was the caretaker, and I told him that same speech. And one day I was leaving Hospice House, and he was a really nice guy. For some reason, on the way home in my car, I thought I'd give him a call. So I called this guy from my car. I said, Al, this is Dr. Francis. How's things going? He says, you know, Doc, And he talked about what I'd said. He said, you know what you said about me being her husband again? He said, you know what we did the other night? Oh, no. We played a game of Yahtzee together. We haven't played a game in 2 years. She had chronic lung disease and had been very sick and had a prolonged course. So we haven't played a game in 2 years, but we played a game of Yahtzee. So, you know, things like that are the things that I remember that make me, come back for more. So now there's all sorts of hospice places. We're lucky in this community to have our hospice house. Lots of times they're in hospitals, they're in special units. It's not so holy. Let's go to the next slide. This is hospice house. I don't know if everybody knows where it is. It's straight up the street, the other end of East Brown Street on the left-hand side. The university built their dorms up here, and when they did that, they had to clear this property, and they had to bring the sewer line up from 447, or from East Brown, so that it made it possible to use this land for hospice house. And I tell people, this is a nice part of the story too, is that it was a combination effort between East Stroudsburg University, because they had to put the dorms up top, so they had to bring the sewer line in, which cut the cost. ESSA put up some money to do it, so it was a combination of ESU and ESSA, and one family donated $250,000. The whole project was about $800,000, and it's been paid for from donations. So this is from the front.
Back arrow.
No, you wouldn't. These are the doors where the ambulance is. And then the entrance to the patients come into the front. This is the front entrance. The ambulance entrance is over here. This is our atrium. That's why I said you can see the open, the lighting. It was
Yes.
really a nice place to have that service. Next slide. I just wanted to get these are my pictures, I apologize. But I wanted to get the lighting so you can see how pretty it is. There's a kitchen area, so families can come and cook. You don't have a lot of patients who really come and cook, but they bring food and they reheat it and so forth. And then there's a dining area, so families can sit and talk and, eat and do whatever. There's a meditation room. This is a waterfall. You can't see it too well on the street, but it's real tall. It's a really quiet kind of place you can sit and just meditate or pray. We have a little kids corner because a lot of times there are children, and we do a lot. The nurses and the social workers have a lot of materials for kids who have a parent that's dying or whatever. This is a nurses station, pretty standard nurses station. This is one of the rooms. The rooms all have hospital beds. It raises and goes down like hospital beds, but it's all cherry wood, so it looks very nice. The floors are all hardwood. And there's a patio, sliding glass door in each room. This is a little angle. This is a sleeper sofa. Every room has a sleeper sofa, so patients' families can stay overnight. Yeah, that's a sleeper sofa. And then this is just, every room has a quilt. These are made by all people that donated their time. And now we have visitors. Believe it or not, I got out of my car, that thing was standing there.
That's for real?
That's 15 feet. I got back in the car and I took a picture of my phone. So sometimes they let a person come close and personal. He was actually, what happened was, on those little sliding glass doors on the patios, they had bird feeders. You can just see the bird feeder over there.
Yes.
And he took every one down. There were 6 beds. He took every single one down. And I took that picture through the glass. So hospice care is concerned with the patient at the end of life and aggressive measures and treatments are withdrawn. And attention is put into comprehensive care. Quality of life, not quantity. Palliative care deals with the same issues, but earlier this is being suggested. Sometimes it can get confusing because doctors talk, doctors speak, so lots of times early on, We'll use terms like palliative radiation. Radiation treatments really don't cure a lot of cancers. They palliate them, they relieve them, they control the pain. So we use that term frequently when we're talking about radiation treatments, or even palliative chemo. Sometimes we'll give people chemo, we know it's not going to cure them. So we want to try to palliate them or give them some time. Next. This is a little bit of the history. Hospices were originally places for travelers back in the 4th century. 19th century, it was religious orders. And then it was Dame Cicely Saunders who first started the first hospice, I think it was in 1967. But she was caring for a man who was dying of cancer from the Warsaw Ghetto. And she fell in love with this guy. And she decided that caring for the terminally ill was something she wanted to do for the rest of her life. So she spent her whole life treating hospice patients and creating the hospice movement. So the modern hospice movement is credited to her. Yes, 1967, St. Christopher's Hospice in the United Kingdom. It's grown substantially in the United States. 2,500 in our country, 1.2 million people and their families receive hospice care. A little bit about hospice under Medicare. Hospice is the only Medicare benefit that includes pharmaceuticals, medical equipment, 24 hours, 7 days a week, access to care, and support for loved ones following the death. So I pointed out access to care because when you're talking to patients, when your families are upset and somebody's dying, they say you have access to care 24 hours. What they think is the nurse is going to move in with them and stay in the house 24/7. It's not at all like that. You have access to the nurses, you have the phone number, you can call, they give you advice and so forth. But you're basically kind of on your own. But the benefit does include oxygen. If you need oxygen, that's covered. If you need pain medication, that's covered. If you're dying from cancer and you have pain, that's covered. But if you also have diabetes or diabetic medication, it's not covered. That's not part of the hospice benefit. The hospice benefit can be revoked. You're allowed to revoke it because people change their mind. People come in. I've already told you sometimes people look like they're dying. They get better, we let them go. Then they say, I want to go back and get aggressive treatment. So you can revoke the hospice benefit. You can reinstate the hospice benefit. Just flip back a minute. There's one other thing I thought. Oh yeah, I think the big thing was the serious. Oh, respite. That's right. Under hospice, we see this a lot. We get patients. Well, there's a couple of ways. We just had a lady who daughter needed cataract surgery. She's going to be Africa. So her mother has multiple myeloma. So we said, okay, we're in the hospice for a respite. So she's in hospice for a 5-day respite while the daughter can go and get her eye taken care of. So that's one type of respite care. The other kind of respite care we see, we get this call all the time. Pain crisis. The patient's in pain crisis. This is one of the reasons I like hospice house and not home hospice as much. So then, of course, pain crisis, I'm thinking, oh my God, I hope I have enough morphine, I get to hospice house, how's the patient? The patient's fine. What'd you give her? Nothing. What'd you do? Well, we just kind of cleaned her up, put her in bed. So really what happened is the caregiver at home was overwhelmed.
Yes.
The patient perceived that no one knew what they were doing. Everybody's nervous and uptight, and everybody's anxiety level goes like this. Hospice house, you don't have that because the nurses are all trained. Most of them have been there. All of them have been there as long as I've been there. So it really does diffuse a lot of anxiety and fear that people have. So what are the diseases? Really, it's not just cancer, it's any disease. Heart disease, COPD, degenerative neurologic disease, dementia, ALS, which is Lou Gehrig's disease, strokes, Parkinson's, multiple sclerosis, kidney disease, HIV and AIDS. We don't see as many. Years ago, we see a lot of people with AIDS. You don't really see any. I mean, those people with new drugs, those people actually do pretty well. Okay, this is the punchline. Now, New England Journal of Medicine, 2010, they took 151 patients who came into emergency room with metastatic lung cancer. This was smoking-related cancers, either non-small cell cancers, which means either squamous cell or adenocarcinoma, all related to smoking. These people had metastatic disease at the time of diagnosis. Their prognosis was probably 6 months or less. They split them into two groups. One group got standard treatment, cancer care, chemotherapy, and radiation. The other group got cancer care and palliative. Okay, so they talked to them about spirituality, about their emotions. They did a depression test, and they repeated it 12 weeks into the treatment. What they found was that patients in early palliative care had better quality of life and lower rate of depressed mood at 12 weeks. Patients with early palliative care had less aggressive care at the end of life, so in other words, they were less likely to end up in ICU, but had a longer survival, 11.6 months versus 8.9 months. And the only difference was we nurtured. I like to say the only difference was we were nice to them. We treated them like human beings. We treated them like we wanted to be treated. That was the only difference. Now, that's a big, when you think of it, that's a huge difference. These people only lived a matter of months, yet we were able to give them 2.7 months. It's a huge improvement. So now there's been some arguments. This was done in Massachusetts General. People say, well, Mass General, man, that's one of the big places in the country because they probably have the best palliative care team in the world. I don't think it's that complicated, just like that wedding. You just got to think out of the box. You got to be reasonable. I think this can be done. But I think, these are the kinds of things that I think are exciting about this field because you say, we all think, well, I want more technology, I want more chemo, I want more radiation. But here's studies that show that maybe that's not the best way. Next one. 2008 Dartmouth study, basically this is saying that what they found, I have to read this to one copy. They went through 4 million patients, and the researchers found significant variations in the way that people with serious illness, such as heart disease, heart failure, and cancer were treated. In the regions that delivered the most care, there's lots of hospitals, lots of imaging centers, lots of stuff, patients have a slightly higher death rate. That doesn't counterintuitive, it doesn't make sense. Than patients with the same conditions treated in areas were treated less aggressively. Patients treated most aggressively are no more satisfied with their care. So not only did they more likely to die, but they weren't happy with their care. And I like these studies because it starts to make us challenge the things that we believe. The cost differences are vast. Average Medicare spending in the last 2 years of life for all hospitals range from a high of $81,000 in Manhattan to $29,000 in Butte. Next one. In regions where there are relatively fewer medical resources, patients get less care. However, there's no evidence that these patients are worse off than their counterparts in high-resource, high-spending regions. So it makes me kind of cool. Patients do not experience improved survival or better quality of life if they live in regions with more care. In fact, the care they receive appears to be worse. They report being less satisfied with their care than patients in regions that spend less and having more trouble getting to see their physician. So even though they have more doctors, more facilities, more hospitals, more imaging centers, they still have more trouble getting in to see a doctor. Doesn't make sense. Most studies have found that mortality is no better in high-spending regions, almost certainly because the benefits of some patients are counterbalanced by the harm to other patients. So that's just kind of summarizing. There's a widespread belief by some healthcare providers that the wider community that medications used to alleviate symptoms may hasten death in hospice patients, morphine, lorazepam, fentanyl, and others. Conversely, and I've already told you this, There's a clinical impression among hospice providers that hospice might extend some patients' lives, and we talked about some of the examples already. I actually like this study. I first stumbled upon this study in New Yorker magazine. When I read it in New Yorker magazine, I did the research and actually found the actual study. But this study was, they looked back, I think over 3 years, they looked at 5,000 Medicare cases. And what they found when they looked back retrospectively was that if you had pancreatic cancer, if you had lung cancer, colon cancer, what other thing? Oh, congestive heart failure. You had congestive heart failure, colon cancer, lung cancer, pancreatic cancer, and you were one of these 5,000 Medicare patients, you lived longer if you didn't get treatment than if you did get treatment. 29 days longer on average in that study. Well, the study's been criticized because it's retrospective, so there may have been other variables. But still, you know, all these things have made me start to think and reevaluate how we approach treating our patients. I think that's pretty much the summary. The hospice care saves money for the Medicare patients. Actual savings are about $2,300 per beneficiary. So I could just summarize this. You can turn that off. Basically, what's happened is for hospice and palliative care is that over the last 10 years, if you go back 20 or 30 years, most hospice care was provided by charity organizations, churches, that type of thing. And then it moved to nonprofits, like VNA is a nonprofit. In the last 10 years, what's happened is there's many more for-profit hospices. So you see the names on TV. These are for-profit hospices. And unfortunately, it's become a booming business. And the for-profit hospices have made it tough for businesses like ours to stay afloat because they can see lots of patients, multiple states. They can afford losses that we can't afford. So the not-for-profit hospices are really kind of suffering right now. Medicare is looking at this because the hospice business used to be a couple $2 billion, now it's up to $10 or $15 billion. Mostly because of this big explosion of hospices. Look at the for-profit hospices. Their length of stay tends to be longer. They seem to be more aggressive at recruiting people earlier, and they tend to stay on the hospice longer. How this is going to end up, I don't know, but I do know one thing, and that is our hospice house is a jewel in this county. We've had patients from all over the world who come, actually we have from other countries, relatives are dying there, and they say, oh my God, you know, we don't have anything like this where we come from. We've had people come from New York, we don't have anything like this in New York. Philadelphia, nothing like this in Philadelphia. So we're really, really fortunate to have the facility we have. So that's everything I know about hospice and palliative care. I don't know if anybody has any questions.
Do you have charity care or a Medicaid? How are you qualified for any level of hospice or anything?
Well, that is the plus that I think the non-for-profits bring to the table. The not-for-profits we see at Hospice House, the Medicaid, the uninsured we see at Hospice House will take care of that. Yes. I can't speak for the for-profits.
I didn't know there were for-profits.
The ones you see advertised on TV are all
Which,
for-profit.
personally, I've worked with subject to rehab, which is profit. I'm not working in those areas anymore. But seeing how they operate and then hearing about for-profit hospice, that frightens me.
It's out there. It's America. We have an opportunity. But there are for-profits, and they're big. And, you know, and truthfully, there are some of them are national companies. So if they have, you know, VNA Hospice, we're not-for-profit. We have about, I don't know the exact number, maybe 30, 40, or 50 patients in our census. if you have 10,000 patients and you're losing your shirt on one patient, it's no big deal, you got 999, a ton of other patients. But with a small hospice, if we're losing our shirt on one patient, we jeopardize the financial stability of the organization. So it's making it increasingly challenging for the not-for-profits, not only here, all over the country, to stay afloat.
Question and a follow-up suggestion. You mentioned you became board certified in '83, but you were
Internal medicine.
right. But your involvement with hospice wasn't until '93. I lost my mother in 1980. She went through hospice. My question to you is, because I'm sure my father will ask me, is what is the most significant change you have witnessed in hospice care since your involvement in it? That would be different from 1980 when I lost my
I
mother.
think the inpatient units, has been a big difference. Like I said, I was a big proponent of dying at home. I would always counsel my patients, you don't want to die in the hospital. Why would you want to die in the hospital? You want to die at home, with loved ones, and family. And then when I saw the anxiety and the stress it created, and how that's relieved by our inpatient facility up the street, I think it's made a huge difference. And it really changed my opinion. If you'd asked me 15 years ago, I would say hospice at home. But today, if it's financially viable, I would say hospice, inpatient hospice. It just takes all the stress away. It's really been amazing. That's been the biggest change.
Thank you. And my follow-up suggestion would be you need to determine how to figure out a synthetic bottled hospice endorphin that we could get to go.
Honestly, I try to get people to come to our hospice house, even other doctors, because I think that, well, Blanche, you've been in there.
Yeah.
I think just the feeling when you go in the doors, I'm telling you, there's a sense of relief. And I take medical students. I have medical students with me from the new school in Scranton. And I always prep them. I said, when you go in here, I want you to feel the difference between this and when you walk on the floor of the hospital. It's totally different. There's no beepers, there's no buzzers, there's no people running around. It's just calming and soothing.
They're not being poked and prodded. They're just living out their life. Better feelings, the endorphins,
Yeah,
the 2.7 extended months on life. That's where it probably comes.
How do you get qualified? How does,
Well, the way, you mean me?
no, qualified for the patient, because our dad has dementia, okay? And he just seemed to take like a really bad turn recently. And we are just now trying to cope with,
Some of those issues.
yeah, trying to get him into a
It's
place.
become increasingly difficult because of the expanding hospice Medicare budget. Once the Medicare expenditures start to get at 10, 12, 15 billion a year, all of a sudden SMS, or CMS, Center for Medicaid Services, is saying, wait a minute, what are you guys doing? So they've made it much more difficult to enroll a patient in the hospice over the last couple of years. Now, the bigger companies, the for-profits, if they get dinged by Medicare and get slapped with a fine, they don't get write a check.
Yeah.
But if you're a small not-for-profit, you can't really take, you have to be very careful, but there are criteria that, I don't know all the criteria off my head, off the top of my head, because the nurses do that for us, but you have to show weight loss, there's got to be a physical decline, and it's got to be documented. There used to be a category called failure to thrive, because we got a lot of people who just get old.
So basically, you have to let them stay at home and decline and document
There has to
it
be
before
some-
they can come here and have fun.
There has to be some decline based upon Medicare.
It's-
So we used to have a one that was called, what they called failure to thrive, it was something like that. I can't think of the title off the top of my head, but They won't even let us use that anymore.
That was my dad's reason on his death certificate.
Something-
Inability to thrive.
Yeah, something like that, there was a term, can't think of it, but they won't let us use that, we can't even use that anymore as a hospice diagnosis. We have to have some other diagnosis.
One more question. Our dad seems to want to die in his sleep.
Who
Okay?
doesn't?
Oh, yeah.
Yeah, really.
That's my first 9 choices.
But he is on oxygen, and up until about like a couple weeks ago, he decided, you know, if he doesn't want to go on it, he doesn't want to go on it. He stopped breathing 90 times a night, and he thought
I
he
wouldn't
should
give
be
it
on
to him.
CPAP.
I wouldn't do it.
Right, so we pretty much have gotten to the point.
You know, if you look at hospice and palliative care literature, there's studies that I can show you in England, they don't use oxygen. In fact, if you have a hospice patient, lots of times we don't use oxygen, we just have a fan, we'll blow a fan over them. It's much more soothing, much more comfortable, you don't have this thing. And half the time, really think about it. Have you ever visited somebody in the hospital? The nasal cannula, which is the probe, usually in the ear, or down around here. It's never in the nose. It's the nose, it's only because somebody put it there 3 seconds before you walk through. It's never in the nose.
Well, we do it only when he's sitting up right now.
If he didn't want it, I wouldn't force it on him.
Okay. It's just, we're afraid
It's my
of it.
opinion.
The alternative is pneumonia, and he's had a pneumonia shot, but, you know, who's to say that he won't get pneumonia? Okay, so, I mean, just supporting him in his decision, we're like, I think we're on the same page that way. It's
As
just,
long as he's pretty with it in terms of his decision making. you can-
Okay.
Oh, when he's making a decision, he's really with it.
are they the right ones? No.
You know, I think it's a matter of what you feel comfortable with, but I wouldn't force oxygen on anybody.
It's just, right now, it's just how do you know, wet him? And you know he's not with it, but he is with it when it comes to, I don't want the oxygen. You know, so I just, like, where is the, how do you watch him die? Like, how do you get to that point in your home to say, okay, he's wheezing now, what do you do for the wheezing if he doesn't want the nebulizer? I mean, he could physically go downhill within a matter of weeks, right?
Hours.
Okay.
Minutes.
If he stops with the oxygen and the, okay.
You know, because I don't know what his pulmonary status is, but yeah, these people can decline rapidly. I mean, I've had guy over at hospice house, I had a conversation with him, like I'm talking to you. He was the last guy in there that day that I thought was gonna die. By the time I got in the office, the nurses called me, guess what, he died. Just like that.
Well, see, I think that's what would happen, you know, and I want to be prepared. I want him to be prepared for his father
But
to die.
see, you're supporting exactly what I just got done saying.
Yeah.
What you're saying is it's scary. I'm afraid of the decisions I have to make. I'm afraid I'm not making the right decision. Am I doing the right thing? Am I doing the wrong thing? Is somebody gonna question me afterwards? You know, when you're in hospice, other people help you with those decisions. They talk to you, they walk you through it, which I think is the benefit, because it's really scary.
It is.
So is he a candidate? We're scared, right? You know, because he's gone one day without oxygen and wheezing.
And maybe for some of us in the room as well, when one of the siblings is in charge of the parent, and you're faced with, you let them do what they want to do, because that's what makes them happy. But then the outcome, you know darn well, is going to be argued by my 3 sisters. Well, why did you let him do that?
Wow, I never saw that before. That's made my, you know, when I tell that story, I tell it differently. When I tell that story, the way I tell it is, daughter from California who hasn't seen mom in 5 years, she comes strolling in, then forget it. Now we got ICU, we got defibrillators, we got pacemakers, we got all sorts of things going on. Because they feel so guilty.
That's it,
They
yeah.
feel so guilty.
Yeah,
And I understand that, you know, but I'm saying, yeah, I hear you. You know, and those are the issues I face every single day.
Maybe it just simply reverts to his do not resuscitate. And if falls on that.
You know, I
Do what he
think
wants to do.
it requires discussion and just, you
Did
know.
you discuss that with him? Say, you know, we're in favor
I
of
would
you doing
discuss, we have
this.
3 sisters,
Yeah.
I'd discuss it with them too. I'd make them get up here and have a chit chat.
You wanna come?
I'm pretty good at it. A lot of experience. No, you know, when I came up here, I used to work in ICU a lot and did all that stuff. Now I go in ICU, I go, what are we doing to these people? This is like some sort of weird, I don't like it. You know, because, you know,
I think he'd rather, I mean, at this point, I think he'd rather die than even get new dentures. You know, he does not want to get, I don't need new dentures, but he can't chew his food and he's getting constipated. I mean, I know,
How old is he?
90.
Oh, player.
I'm like, do we take him to get new dentures or do we start just like
What does he
whitening
want to do? He
everything?
don't have to be 90, he can do what he wanted to
He
do.
goes
Yeah,
to
I
the
would
VA
too.
once every 3 months to get his toenails cut, and that's it, and he complains about it.
any other questions?
So if that man was in the hospital and they wanted to put him on oxygen, do they have the right to say he doesn't want oxygen? Or are you gonna have a patient advocate saying, no, no, you can't do that?
They would have the right to do that, but by the same token, they would probably say, okay, if you don't want us to give him oxygen, why don't we discharge him?
Yeah.
Okay,
Yeah.
okay.
Why is he here?
So now hospice care, hospice house, that profit or nonprofit, is that
Not
covered by
profit.
Medicare and your supplemental insurance or no?
It's more complicated. Medicare generally will pay for the first 48 or 72 hours. After that, they won't. And it depends on the patient's condition. If the patient's condition, for instance, better that I answer an example. Patient comes in, they're having pain, they have cancer, and I put them on morphine twice a day. Next day I come in, I'm fine, doc, that pain control's good. Next day I come in, pain control's good. Medicare sees that as not really requiring hospitalization in a hospice hospital, so they'll stop paying. If they come in, one day I give them pain control, oh no, it's agonizing the next day, I'm vomiting, I treat that. The next day, oh no, I have diarrhea. So if I'm actively treating symptoms that require intervention, that Medicare will continue to pay for a longer period of time.
So what is the cost of a person has to
It
self-pay?
just went up, I think it's about $300 a day. A lot of people with supplemental insurance have coverage for that, so that works. Some of the Medicaid patients, we have contracts with Medicaid, and we just,
So Medicare covers if you have hospice and home care?
depends on the policy, depends on your supplemental policy. Some of the supplements, like glucose and Blue Shield, don't have a hospice benefit as part of that.
Does, different states have different admission requirements for hospice?
Not that I'm aware of. I think that's, most of the money that's paid to hospices comes from Medicare.
Right.
And I think the criteria is the same in all states, but different organizations have different levels of thresholds to accept a hospice patient because, like I said, the small not-for-profits have to be very careful. The big for-profits, if they get a fine from Medicare, they go, well, okay, so we stretch a little bit. It's really, it's a system that, it's a shame because if it's set up right, it really would be a great system. It's just not set up right. Whether the government will ever be able to straighten it out, I don't know. I have my serious doubts.
I can share this with my mother had kidney dialysis, and she had cancerous polyps that she had removed, and the doctor said, do you want to do chemotherapy? She said no. She said, I want to just, let things go, see how it all happens, rather than go through all the side effects. My mom had 3 years of good quality of life and doing the dialysis as well. Although as she progressed, it got worse. Her cancer started to spread, because she didn't have any treatment, to get it off, whatever. And so her dialysis treatments were getting shorter and shorter to the point where she wasn't getting the 3 days a week that she was supposed to get. This was right around Christmas time, 1997. And one day she went in, it was in January of '98, and she went in for dialysis and looked at everything and said, no more, I'm done, take me home. Now, at that time in Phillipsburg, New Jersey, Warren County, there wasn't any hospice house, and Sussex County, New Jersey just developed a hospice house, Jefferson. So my mom wanted to go home to die, called the doctors there, the nurses and everything, family. We went home. That was on, I think, a Monday. My father, in his mind, had it set that, well, Mom has 2 good weeks to go. I said, no, Dad, Mom will probably be gone by Friday, by the end of the week, because she was very ill. Hospice came in, it was Karen Ann Quinlan, came in and set everything up. They were wonderful. We had the chaplain there, the nurses were there. I was the primary caregiver. We had, my mom and dad had been married 50 years in August. So we had a 50th wedding anniversary for them. My mom had a corsage. We had little drinks, and as long as my mom could still eat something. So we did celebrate that. I was given morphine to give to my mom. And it was on a Thursday night. And it still bothers me. She was actively dying, and I was giving her morphine. It was Friday morning around 5:30. I called my brother, got my father, and everyone came. And Mom died. As the primary caregiver and giving her this morphine, and it was very interesting too. As she was lying in bed, she was reaching up, and she couldn't talk at that point. I wanted to find out, what are you seeing? What are you seeing? Because she couldn't tell me. But even though my mom passed away, I knew she was dying. I felt responsible for my mother's death because I was giving her this morphine. So in my mind, I felt as though I put her into respiratory arrest. And I did have to go to counseling for that because I felt so responsible. So I think having hospice house like this does take that burden off of the caregiver.
Well, doctor, maybe you could ease this woman's pain. Do you feel the morphine killed her mother or the dialysis?
Well, I know the morphine did not.
Docs, we have to go through this too, because docs, we don't talk about them much, but honestly, docs always second guess ourselves. We're human too. And, what I say to people like her, no, a renal failure killed your
That's
mother.
right, yeah.
Right,
Renal
yes,
failure. The renal failure, the infection killed Mom, the cancer killed Mom,
Right.
not the morphine.
Right. And at
The
that
morphine
time-
gave her the last bit of comfort that
Yes,
she had.
yes.
So, but it's a difficult thing, and think about this, another thing I talk about. My son's gonna kill me. But another thing we talk, that I tell people is, think about it, let's back up to 1952. I was born in 52. My father's mother, my grandmother, on my father's side, died in the living room. Now I remember that? I remember that because I remember going to see her. She was in the living room, in the bed, okay? And she was sick. She had bad diabetes. There were no treatments back then. You just got sick, you died. But I guess my point of that is we were all taught to die, how to die, and what death looked like back then. But then all of a sudden in the 60s and 70s, nobody died at home. They died in hospitals. So we don't teach our kids how to die. We all learned, that's my first vision of death was that. I still remember it. I don't even know how old I was. 3, 4, 5. But, we don't teach our kids how to, we teach them how to brush their teeth, we teach them how to say thank you, we teach them all this stuff. And we don't teach them how to die. So none of us are very good at what it's like. Which is another reason hospice is a great asset.
I think to people that are in the medical field, when we're trying to help our loved ones, transition, I really, feel for her because I felt like it was my fault because I couldn't make my father better. and I wasn't expecting, he didn't have the typical symptoms that they have when they're near dying. Went upstairs and I fell asleep, which I never do. And it was when I was drifting off, I felt like somebody was lifting the weight off my shoulders. And we had in-home hospice, and that was in '95. And yes, he had pain, but they put a patch on him, and we lost him for 2 weeks. And when I called the doctor and the pharmacist, they said, take it off. And I got, reamed out for having it done. And they wanted my notes. I said, these are my notes on my father. They're my own notes. You can't have them. And when he came to and was lucid again, he said, didn't you hear me calling you and telling you to get me out of my body? And, he lasted longer than they expected because of the care at home. And it was calm, and they didn't come in a lot because we just said, you come in and do what you have to do, and then you have to leave. They said.
I think it makes a big difference.
It does, but it took me a year after he died, because I thought it was my fault for not making it better.
It's very traumatic. That's why I think it's now I think it's much better in hospice now.
But he was peaceful when he passed away. They said, they don't usually see that, the expression wasn't grimace. They got his teeth in right away. His hands weren't clenched. And whoever came for him, he was ready. But it is hard.
I volunteer over at Hospice House. I've been doing it for about 3 years. And I go 4-hour shifts once every 2 weeks. It's usually a Tuesday afternoon from 4 to 8. And what I can tell you about my experiences there are the nurses are so dedicated to making sure that people are comfortable and they are in charge of the things that they can be in charge of. A lot of times you'll have patients that are fearful or they just want to have control over some part of what's happening to them. So there have been times when I have played cards with people, and when this woman was beating me at cards for 6 weeks. There have been times when I have sat with someone who was only breathing 16 times a minute or was breathing 40 times a minute. And, I'll do things like I'll watch breathing patterns and go tell the nurse when things change, or, you feed somebody a meal, or you keep them comfortable, or you just be with them while they're there. So what happens in Hospice House is all about supporting the family and letting the person be themselves in a way that they're comfortable and safe, because you can't change the outcome.
I think, just to supplement that, is I think that the volunteers are a critically important piece of what we do, because to me, the saddest thing I ever see is when I go in there day after day, and there's no family, no patients, there by themselves, and every once in a while there'll be somebody, I'm calling about room 3, is he still alive? I'm from New York, I can't get down there, and I'm there like, are you kidding me? Really? So the volunteers oftentimes, I'll go in the room and they may just be reading, they may be reading something from the Bible, they may be reading a book. There's music, CD players in the rooms, they may have music on. But it's really sad when you go in there, there's nobody around. So sad. Any other questions? I hope I didn't bore you.
I'm Nancy Yost. I'm a resident here. I've also 30 years in the Department of Social Services in New York City. I was involved in home care and nursing home care. And so I'm familiar with the good and the bad. This place is excellent. It really is. Now, I get certain individuals at certain times. I have disagreements. I try to deal with it personally and the whole thing. But this place, I can tell you, from personal experience on both levels, this place is very good. But you can talk to other people, okay? And I would suggest talking to some of the residents here, some of them, okay? Because, some of us will complain about anything. Even me, okay? So, Okay, it is, and I just now realized, and really, I just realized you're standing there. So I'm not just doing it to show her. I said, oh my, okay, no.
Thanks, Dr. Francis.
I'm gonna go back and watch my TV.
All right, so if anyone's interested in sticking around, we have